Welcome to Trauma Matters, a podcast series inspired by the Connecticut Women's Consortium's quarterly publication in partnership with the Connecticut Department of Mental Health and Addiction Services. Trauma Matters is dedicated to the dissemination of information on trauma and best practices in trauma-informed care. In this episode, Emily Aber, licensed clinical social worker, asks the expert Dr. Debbie Korn. Debbie Korn, PsyD, maintains a private practice in Cambridge, Massachusetts, and is an adjunct training faculty member at the Trauma Center in Boston. She has been on the faculty of the EMDR Institute for the past 25 years and is the former clinical director of the women's trauma programs at Charter Brookside and Charles River Hospitals. Dr. Korn has authored or co-authored several prominent articles focused on EMDR, including a comprehensive review of EMDR applications with complex PTSD. She recently co-authored a chapter on EMDR therapy with Dr. Francine Shapiro, the developer of EMDR therapy. As a clinical teacher, researcher, and consultant, Dr. Korn is known for her knowledge and integration of many different clinical models. In training and consulting on complex, chronically traumatized cases, she believes that it is important to carry a large toolbox and to remain flexible, practical, and integrative. Our interviewer, Emily Aber, LCSW, maintains a private psychotherapy practice in Hamden, Connecticut, where she sees both adults and children. She has over 35 years of experience in various clinical, supervisory, and administrative roles in community-based and inpatient programs. She was a founding member and past co-chair of the Connecticut NASW Clinical Social Workers Network and is a volunteer with the Greater New Haven Trauma Recovery Network. Emily is certified in EMDR, is a consultant in training for EMDR, and completed training in hypnotherapy and as a yoga teacher. Without further ado, here is the interview.
So to start with, how did you become interested in the field of trauma treatment?
Well, I attended graduate school at the School of Professional Psychology at the University of Denver in Colorado. And while I was in school, I had the opportunity to see clients, individuals, couples, families during my field placements at the local community mental health center, the Denver Police Department Employee Assistance Program, and the Disabled American Veterans Outreach Center. So I saw veterans, I saw domestic violence and sexual assault cases, I saw survivors of childhood abuse and neglect, I saw clients dealing with medical trauma, and I worked with police officers and their families following critical incidents. And the key here is that I received excellent supervision and tremendous emotional support in working with traumatized individuals and families. And lo and behold, many, if not most of my clients significantly improved. And I found that I just loved that I could help folks finally put their past in the past. Mm-hmm. And I loved that I could help them move from feeling like a victim to a survivor with dignity and power to someone who could thrive in relationships and in the world. And from the beginning, I loved the challenge of working with very complex cases and found that psychotherapy with this population was incredibly rewarding and hopeful. And I was deeply moved by my clients' stories and by their experiences, and could always see their potential for healing and post-traumatic growth. So I was kind of hooked from the very beginning of my training, and I completed my pre-doctoral internship at the Brockton VA Medical Center working with Vietnam veterans and their families. Mm-hmm. And I knew at that point in time that I really wanted to devote my career to working with trauma survivors. And a small side note to this story is that one of my dearest uncles was a Holocaust survivor. Mm. And I always felt like choosing to work with survivors of trauma was somehow a way to honor him and to honor his suffering at the hands of the Nazis.
Mm-hmm. Yeah, good inspiration.
Mm-hmm.
What do you consider to be core competencies or skills that are essential for a trauma therapist?
I think a competent, effective trauma therapist looks through many different lenses when treating clients. He works experientially and tracks many different phenomena, affective, cognitive and behavioral, sensory motor, defensive, dissociative and ego state or parts phenomena. She or he attends to relational and attachment dynamics, including reenactments within the therapeutic relationship. Mm-hmm. He looks through the lens of interpersonal neurobiology and affective neuroscience and thinks about the concept of co-regulation or dyadic regulation, at times kind of serving like the client's auxiliary cortex, keeping him or her within a window of tolerance. Mm-hmm. I also think an effective trauma therapist uses a phase-oriented approach and prioritizes safety and stabilization prior to moving into any trauma-focused work. He helps to develop self-regulation strategies and works moment to moment through kind of interactive regulation to make sure that the client doesn't get emotionally overwhelmed or flooded and doesn't in turn dissociate or shut down. And she or he provides relevant psychoeducation about trauma, about emotions, about attachment, dissociation, and the recovery process itself. And I think an effective trauma therapist is always ready to serve as a true other, right? Sitting in as a good enough parent, mm-hmm. providing corrective emotional experiences and offering relational security and consistency, validation, and respect for the person's defenses, resilience, resources. She guides and responds to clients from a self with a capital S, kind of a self-possessed place, a stable self-possessed place, guiding the client with presence, with empathy, persistence, playfulness. And a trauma therapist, a competent trauma therapist, welcomes all parts of the person and invites opportunities to process past experiences imaginally, welcoming the client to say or do what couldn't have been said or done in the past, mm-hmm. offering opportunities to bring one's child self the comfort or the recognition that was missing in childhood. And ultimately, I think the therapist aims to bring the client to a place of completion, of adaptive resolution, and is always, always focused on integration, helping the client to achieve a kind of a felt sense of wholeness with a cohesive narrative and a connection to the full range of experience, to feelings, thoughts, somatic experience.
Mm-hmm. Okay, thank you.
Can I add one more point, actually?
Absolutely.
I just thought of one additional point as I was speaking. I just wanted to say that I think it's incredibly important for trauma therapists to be educated about dissociation, mm-hmm. so that they're able to identify when they're treating someone with a dissociative disorder like DID, mm-hmm. and develop an appropriate treatment plan. I just can't begin to tell you how often I discover that colleagues have failed to diagnose a dissociative disorder. And once they begin to see their case from this perspective, their work takes off as they intervene in more appropriate and effective ways. Mm-hmm. So just mm-hmm. wanted to add that.
Oh, good. Thank you. It's important. How do you integrate different trauma-informed clinical models in the treatment of complex trauma?
So personally, EMDR is my primary treatment model, mm-hmm. but I regularly integrate other trauma-informed models into the standard EMDR framework. For example, I use internal family systems, IFS, language, concepts and interventions during the early stages of EMDR in preparing a client to process traumatic memories. I work to identify the protector parts of the person who hold concerns about the proposed work, parts who may block access to memories or affect or introduce substances or dissociation or self-injury or even suicide in an attempt to manage or distract from emotional pain or knowledge. And in approaching these parts with curiosity, compassion, appreciation, it's often possible to get them to step back, allowing access to traumatic memories or exiled traumatic or traumatized parts. Only then is a client really able to safely and effectively proceed with the desensitization or the processing phase of EMDR therapy. Similarly, during the early phase of treatment, I might use strategies borrowed from AEDP, Accelerated Experiential Dynamic Psychotherapy, to strengthen the sense of safety within the therapeutic relationship, making it possible for the client to lower their defenses and then explore their internal world and their traumatic past. ADP is a model that offers a beautiful framework for addressing attachment, for building trust, and for moving clients to a place where they're able to relinquish their maladaptive defenses that are no longer serving them well. Mm-hmm. And early on in the work, I may also engage in some biobehavioral or somatic resourcing exercises with my clients borrowed from sensory motor psychotherapy or somatic experiencing to help them feel more regulated or grounded, more empowered, and more prepared to handle triggers in their day-to-day life, and more prepared to process traumatic material in sessions. Similarly, I might introduce some hypnotic ego strengthening interventions to strengthen clients' capacity for affect regulation and dual attention. And when I refer to dual attention, I'm talking about that ability to observe the past while staying completely grounded in the present at all times. Mm-hmm. And then sometimes I simply teach coping or self-regulation skills borrowed from more cognitive behavioral models like dialectical behavior therapy, DBT, or Lisa Najovitz's Seeking Safety. And once I begin to access traumatic material at a somatic, emotional, cognitive, imaginal level, I continue to call upon these other models as needed. So in EMDR, when we utilize interventions called interweaves, this is a place where I might call upon other models. We use interweaves, or we call upon interweaves when a client's processing is blocked, or when a client needs more information or new perspective. So sometimes I may intervene with an IFS interweave, sometimes with an ADP interweave, sometimes with a sensory motor psychotherapy interweave, so on and so forth. Mm-hmm. The EMDR model dictates that I use an interweave, but the language or the form of the interweave can certainly be borrowed from other models. So with interweaves, I may ask a part to step back or to not overwhelm the adult self to address blocked processing, and we call that unblending in IFS. Or I might use the language of secure attachment, like, I've got you, you're not alone now, I can see that you're scared, but I'm not going to let you drown. I might use language like that to help modulate anxiety and the client's desire to avoid or flee, and that comes from ADP. Mm-hmm. Or I might encourage a client to stand up and push against a wall to feel her muscles and to move out of a frozen state associated with a memory of past abuse. And that's something that I learned from sensory motor psychotherapy that involves reorganizing from passive to active defenses. So many of the trauma-informed models share common goals, and emphasize similar concepts and interventions. What's important, I think, is to be clear about what you're trying to do in any given moment, and to be clear about the clinical goal or the need at an impasse or at a particular stage of treatment. So does the client need a relationally focused intervention, or a mindfulness focused intervention, or a regulation focused intervention? Does he or she need information or a different perspective? Does he or she need defense work or an ego state or parts intervention? Is the client ready for processing work? And if so, does he or she need to focus on completing truncated actions like expressing anger or fighting back? Does he or she need to focus on developmental repair, like connecting an adult self to a traumatized child self, to offer comfort or reassurance? Or is the focus simply on sequencing or processing through the traumatic experience to lower the fear or distress associated with PTSD? Again, many trauma-informed models offer interventions appropriate for these tasks. So depending on what you're trained in, or what you're most comfortable with, and what kinds of interventions seem to resonate most for your client, you can choose what intervention to use with a particular client or at a particular moment in time.
Okay. Are there stabilization tools or tool that you, in your practice and experience, have found most helpful to teach trauma survivors, or is this a "it depends" kind of question?
I would say there's a basic repertoire of skills or tools that are particularly useful, and then from there it depends on who you're sitting across from and what they need in a given moment. I tend to offer clients a wide array of tools over the course of treatment, with an emphasis on self-regulation skills that are designed to be used to downregulate hyperarousal or to upregulate hypoarousal. I emphasize self-soothing skills like diaphragmatic breathing, safe place exercises, and other imaginal resourcing strategies like calling up images or words associated with nurturing or protective figures in one's life. Mm-hmm. I introduce distancing and containment skills, like putting intrusive memories or images or sensations or emotions up on a screen or behind a protective barrier or in some kind of container. I offer grounding and orienting strategies to help the client stay present, embodied, and connected to the current moment. I also teach skills to facilitate modulation and titration of affect, like the use of an imaginary affect dial or a remote control, or imagery that allows the client to tackle just one feeling at a time, or a drop of a feeling at a time, or whatever he or she can handle. I might also teach folks to pendulate, and this comes from somatic experiencing. Mm-hmm. I might teach them to pendulate between safe place imagery or a calm, safe place within their body and upsetting, challenging, traumatic material. And perhaps most importantly, I teach clients how to unblend. And again, that's an internal family systems term. Mm-hmm. I tend to teach them how to unblend from overwhelming states and traumatized or protective parts of self, and how to maintain a witnessing, mindful stance, observing their parts, their emotions, sensations, memories from a distance and with compassion and curiosity. In EMDR, we use the metaphor of a train traveling down the tracks where they're just noticing whatever is arising for them, arising within, as if they're watching the scenery going by. Mm-hmm. And I also tend to work on practical self-care with folks, like appropriate sleep hygiene, exercise, nutrition, boundary setting, and assertiveness or interpersonal effectiveness skills. I work on all of that early in treatment in helping them to establish safer and more stable relationships and practices in their day-to-day lives, and also in helping them acquire the kinds of skills that will be helpful to them as they move into trauma processing.
Well, thank you, Dr. Korn. Our time is just about up, and you've given us a lot of food for thought and really a curriculum of study for the trauma therapist. So thank you very much for being with us today.
You're very welcome. Thank you for having me.
Thank you for listening to this episode of Trauma Matters, and stay tuned for more. You can find this interview as well as a full archive of our newsletters on our website at womensconsortium.org.